Hello, I'm Dr. Nockowitz.
This is Tim.
What do we have here?
This is Tim. He's been in the shelter for 3 days now. And he was with his fiance and his 4 daughters when the tornado struck. He doesn't know where they're at, very anxious. He's been on lithium and been off of lithium for 2 months now. And feeling very down and depressed and has some feelings of suicide. We've got a heart rate of 95, blood pressure 115/90, respiration's 25, oxygen saturation 99%, and he has a 99-degree temperature. He's feeling sleep deprived, lethargic, and depressed.
Hey folks, bear with me, I figured out what it was. I unplugged my MIFI because I was trying to move it to where there was better reception and it died. Let me plug it in.
I thought you were writing a long time.
No, I lost it after you did the vital signs. It just went dead, and I'm like, oh, I bet it was this. Let me plug it in, and we'll be back in action.
Unit, or it's all off-site?
It's all off-site, but there would be a nurse in the shelter that would take the patient along that visit.
Now I'm at a nursing training center in Mansfield, but I've been a director of nursing in the area nursing homes for the last 8 years. And we in Ashland, Mr. Mayor had used behavioral health care unit, and it was through the CPN system. They always sent a nurse out, even though we were there as nurses. They sent their own sort of talk the lingo with them, and they would be with the patient, and so that's why I was
Actually,
Here we are, everybody. Sorry about that.
He's on the other side of his room.
That was,
did he?
can you hear me?
Yes, we hear you too.
Did you get all of the vitals?
You can hear me?
Yes, I can hear you.
Okay, all right. I'm sorry, that was stupid of me to have unplugged that. I apologize for that. Tim, is there anything, nurse, that you can share with me besides the vitals? I think you were saying some things after that.
Well, he feels sleep deprived, lethargic, depressed, and he's been off the lithium for 2 months now.
Right. Okay.
And some suicidal
Tim.
tendencies.
Yeah, I actually did catch all that. Thank you very much. So, Tim, have you ever gone off of your lithium before?
Yeah, there's been several times where I've tried to go off of it. I just don't like the way it makes me feel. I can't, motor control issues and just don't feel quite right. So yeah, I've several times over the years tried to go off of it.
Okay. That's understandable. I mean, lithium can have a lot of side effects, and, you're not alone in wanting to not have side effects from your medications. I mean, a lot of people stop medicines for that reason. So there's no point in me telling you shouldn't have done that or anything, because nobody wants to feel crummy. Is that correlate with any lithium levels that you have? Like when your level gets too high, you feel those coordination issues, or is it just sort of all the time when you're on the lithium?
It seems to be just when it's higher.
Oh, just when you're tired?
No,
Okay.
No,
when the levels,
when the levels are higher.
Higher.
Sorry, when the levels are higher. I'm sorry.
he feels that way when his levels are
Oh,
higher.
when your level's high, okay. Have you been able to figure out what kinds of things make your level high? Like, is it when you get dehydrated or to take antibiotics or diuretics or anything like that?
No, I've never had anything where I found a relation like that. No.
Okay. How often does it happen that your level bumps up a bit and you start to feel crummy from the medication?
Usually every couple months when I'm on it.
Okay. So that's often, and that's a lot.
Yeah.
Yeah. Well, I know this probably isn't the time for a major kind of medication change, but you're feeling depressed and sleep deprived and suicidal, because you're off of your lithium. And we obviously can get you back on that, and probably, within a handful of days, maybe a little bit longer, you can start feeling better. You do realize that there's that connection between getting off your lithium and being depressed, right?
Yeah, I can see that, but I mean, it's a hard choice to make to feel awful on it or go off of it, and I feel so good sometimes when I'm off of it, so.
Right. No, I completely understand. And I was just starting to explain that, the simplest thing to do would be to get you back on it. And it seems like kind of a weird time for medication change here in the shelter in this crisis situation, but I think we probably should talk about changing the medications and starting you on something different that will help stabilize your mood and get you feeling better and not suicidal, because you seem to, on a pretty regular, consistent basis, have problems with this lithium. The level sneaks up and you start to feel real bad, and this stopping and starting the medicine and the going into recurrent episodes of depression is a bad thing for your brain, actually. So, I would prefer to talk with you about finding a new medicine that we can get you started on right now, and you can follow up with your doctor.
Right.
That will hopefully agree with you better, and you'd be willing to stay on and won't make you feel crummy.
I'd be
Does that
willing to
make
try
sense?
it.
Does that sound like a decent plan?
Yeah, I definitely would be willing to try anything right now.
Okay, all right. Have you been on other medications in the past to stabilize your mood?
No, that's all I've ever tried.
Just the lithium.
Yeah.
Okay, so wow, that was the first thing they tried, and you've
Yeah.
just been on that. How long has that been?
About 15 years off and on.
Okay. Yeah, literally off and on, right? Okay. Is there a history of bipolar disorder in your family?
No.
Okay. Do you use any kind of alcohol or drugs?
No, I do not.
Okay. Do you have any medical issues? Or well, let's just start with medical issues.
No.
They've been checking your labs for thyroid and kidney disease, being on the lithium all those years?
Yeah, so far everything's within the acceptable levels.
Okay, good. Good. Sometimes what happens with lithium is it can make the thyroid levels low, and the depression can actually be from having a low thyroid after a while, and not so much due to the medicine itself, but the thyroid condition that resulted from the medicine. So I'm glad to hear that your thyroid is okay. We're going to be switching to lithium anyway, but I'm glad that your thyroid's okay. Any history of head injuries or seizures or sleep disorders?
No.
Okay. Any allergies to medications?
No.
All right. Do you have any family history of diabetes or high cholesterol?
Yes, high cholesterol, my dad.
Okay. The medicine that I'm going to recommend, it's a good medicine, and it's in, it's not so much this medicine itself, it's in a class of medicines where they all do this. Sometimes they can bump people's blood sugar or cholesterol up or cause like hunger or weight gain. Most people do not have a family history of cholesterol. That, you know, be smart to follow up with your doctor, you know, and have that checked periodically, once a year or a couple times a year, just to make sure that it's not doing that to you. Is that something that would be all right with you, acceptable to you?
Yeah, I'm trying that.
Okay. Yeah, I mean, you know, all the medicines have potential issues. It's just a matter of being aware of them and monitoring for them. It's kind of like you were doing with the lithium, where you got to check thyroid and lab tests and lithium levels and all that. You know, there's a thing or two to check with this class of medicine too. But I think it'll do a really great job at stabilizing your moods without causing any of the motor control issues or feeling crummy or the way you get on the lithium. It's a completely different class kind of medicine. And it's been out for years and does an excellent job. There's actually 3 classes of mood stabilizers, 3 different kinds. Lithium's one, and this other category is another, and then seizure medicines are actually the third. Seizure medicines actually can have a lot of side effects. That's why I'm not choosing that field. I'm trying to pick one that's going to be really easy to take once a day, and hopefully very well tolerated for you. So I think with our staff there in the shelter, we're going to be able to get access to those medications, and it would be something that we would start tonight. It would be 1 pill at night, and we're going to keep a real close eye on you, make sure you get better and you're doing okay. If you have any suicidal thoughts or anything like that that gets worse or that you're concerned you might act on, please let us know right away, because we're here for you and we'll make sure to keep you safe. Does that sound okay to you?
Yes, thank you.
Yeah, you're welcome. Do you have any questions for me about any of that right now?
No, not right now.
Okay. Well, Tim, it's really nice meeting you, and I'm sure that we can get you on the right track with your mood and your suicidal thoughts. And I'm glad that we're trying something different, because this history of being on a lithium is really not working out for you, sort of in big picture. So we'll get you taken care of. Okay?
Okay, thank you.
Thank you.
All right, well, you take care.
So who does he give the order to? The nurse or
Yes,
the
yes. The
nurse?
nurse would give the order.
And you call the pharmacy?
Right, yes, exactly.
So Tim has bipolar disorder, and he's been on lithium, and lithium has lots of side effects. And a lot of people stop their medications when they have side effects they don't like. You know, it's a very subjective thing. You know, you can't say, well, those are mild, you should be able to put up with those. If they bother a person, they bother a person. And here he is in the situation, the shelter, depressed, suicidal, and all this stress. And I think it's a weird time to start new therapy, but I think it's smart. Sometimes when people feel a sense of hopefulness that they're going to get on the right track now with a change in their treatment, you know, that goes a long way. And so I decided to make the change. I heard Dr. Lester did, and she put him back on his lithium. But I decided to make the change because I think that'll instill a little bit of hope in him that things can be different and better in the long run.
So what medication would you prescribe him?
What I was going to prescribe for him is called Symbyax. It's a combination of Prozac and Zyprexa in 1 pill. So 2 different medicines in 1 pill, once a day at bedtime. And it's really nice because you can adjust the doses. One of the medicines in there is an antidepressant, and the other one is a mood stabilizer. And it works much quicker than a lot of other things because the 2 work what they call synergistically. They kind of boost each other's effect, and it kicks in quicker. Usually within a handful of days or a week, people start feeling something. And it's nice because you can adjust the dose of each of the 2 medicines. Like I'd start them on probably the lowest dose, 325 milligram, meaning 3 of 1 milligrams of one medicine, 25 of the other. So the pill's 3/25, but they have like a 625, they have a 650, they have a 1225, a 1250. So depending on a person's symptoms, you can adjust it. But I think he would do really well on the 325 to get started. He has that hopefulness now about being on a medicine that's not going to be the same old, and he's going to have the same problems and just this sort of sense of despair and discouragement and side effects. You know, because everything is doom and gloom to him right now, so he needed a sense of hope. And I do feel hopeful about that med choice, and I think he would probably do okay.
Now, when you start him on a new medication
Yeah.
like that, in a situation like this, do you do a follow-up to make sure he is okay?
Absolutely, yeah. I mean, anybody with a new medicine, if we were getting him back on his lithium and he's been on it 15 years and we kind of know how he feels on a given dose, we probably still want to check in with him, but it's not as critical as a new medicine. I mean, we want to check in with him, you know, the next day or something, a couple days later for sure, and just make sure it's agreeing with him and he's doing okay on it. Because that whole sense of hopefulness, you know, might be not there if he hates the medicine or he
You
feels
send that
worse.
report to his physician then?
Oh, absolutely.
So that there's
With-
contact that way?
Absolutely. With our system, I'm writing a note back there that's done by the time we're done with his visit, or within, you know, a minute afterwards. We have a very efficient note. And it'd be right in the system, emailed over to whoever his doc is, you know, either that day or, you know, whatever. Yeah. Yes, sorry.
Well, another thing to take into consideration, sometimes when they're in a shelter
Yeah.
situation like this and they've had a traumatic event,
Right.
there's a weight loss. If they're not eating and they're, you know, maybe they're not sleeping, their metabolism might be up a little bit and they might be, you know, and their dose might very well be a little higher, say if they've lost 10 pounds
Mm-hmm.
or more.
Yeah,
you know,
and
it could
hydration
cause side effects that
and all that.
maybe, yeah,
Yeah.
right.
No, I mean that's a big issue. And people that were, if he had presented on lithium and was having a lot of side effects, I would have asked a bunch of questions about hydration and weight
Right.
loss and all that.
Right.
Because dehydration, which can, you know, potentially happen in a situation like this,
Right.
is one of the main reasons for lithium toxicity. When you're dehydrated, your lithium level is more concentrated in your blood, and you have all kinds of symptoms. So if he was feeling crummy and depressed and having a lot of side effects from the med, but still on it, you're exactly right. Being off at 2 months, it's really not so much of an issue. And in terms of dosing some of the other medicines that aren't as dependent on hydration status, like Zyprexa is not so much. Lithium definitely is. We don't worry about it. There's something called the blood-brain barrier that the medicines cross, and it's not like antibiotics and things like that where you dose according to their weight and things. It's different. It has a different concentration in the brain than it does in the body, in the plasma. Yeah, so just things like that to factor in. But that's a great point about the lithium and the hydration and the weight loss and all that. Absolutely.
I have a question.
Yeah.
Through your evaluation, if you determine he's just suicidal in relation, he's not safe in this environment, would you tell us at that point we should try to go to get him to the nearest psychic unit? Would you help get him into that unit, or do we have to do the legwork to try to get him in somewhere?
No, we have set up a network of places that we can do direct admissions to.
Okay.
So that, and we try to have it regionally, you know, and we've been in touch and have contact or relationships with somebody to avoid all that ER
Yeah, it's very
stuff.
complicated.
It's very. And
We don't have the help of this.
We have people, you know, in the central region, we have people in the northwest region, hospitals that we have direct lines of communication where we can do a doctor-to-doctor report and say, we have a patient, they're in a shelter, or whatever the situation might be. You know, they're suicidal, I need them admitted directly, we need to bypass, you know, don't stop but go, right? You know, just like right into the unit. So yeah, this was his usual dysphoria, hopelessness, depression that he gets when he's off the lithium. He wasn't acutely, you know, suicidal. It's just the state of affairs right now. And yeah, I could have assessed it better, but it was just the feeling I got that this is how he gets.
I just want to make sure that's something that you
Oh, absolutely. No, I mean, that's critical. You know, that's one of the main concerns about setting up a system like this is, and that's why we started, you weren't here for this, but when we first started doing this, we set tele-psychiatry up in primary care offices, their primary care office. So, you know, they were known to the staff and to the doctors, and also if we had an issue like that, we could call the back office staff and go, hey, you know, Joe Smith is not good in there, you gotta get a squad over there. So we really have thought through that, and we feel better having those connections and the direct admissions and all that before we care for people. You know, we have everybody's like addresses where they are at the start of each visit. We know where they are, and
and things like that.
And then by chance, I missed it.
That's okay.
But, we would need to make sure our hospital, well, and squads would bypass, try to check out the physical. So lots of times, even though we might have had an order to go to psych, they still want to, you know, their rules sometimes are we got to go to the hospital, make sure there's not physical. The problem is,
Yeah.
sometimes they don't ever get back where they need to go.
You're so right, and that's why the places that we choose, that's one of our main criteria, is would you be willing to accept them on psychiatric grounds and do the medical workup once they're there? Because a lot of them want them to go to the ER, get the whole workup, and then, like you said, who knows what happens from there? You know, the plan might get diverted somehow, and they may end up in a different place. Yeah, so the places that we work with are willing to take people directly and, you know, do the medical workup immediately when they're there.
Well, let's say the shelter closed in the morning, you talked to him in the evening,
Yeah.
got this medicine started. You have the demographics on that patient, you know where to contact him after he's left the shelter, and physician and everything. I mean,
That's
people scatter.
That's a good question. That's a great question. The truthful answer is we didn't. We just were asked to come and we showed up today. We didn't think through that. But that's a great point. You know, because before we saw people, we would really need to know who they are, what their address is, and just all this kind of thing,
Yeah,
where they're
because
going after.
They're out of here once
Yeah.
they're released.
I
Well,
didn't
it
think
would
of
be
that.
helpful to make sure that they had our information, because
Yeah.
we're,
At very least, right?
at the very
Yeah.
least, yeah, that they can
What kind of
contact us.
patient profile do you get when you treat like this?
We'll always be followed, yeah, okay.
Well, we don't.
That's the same type of question.
We don't treat at shelters. I mean, we certainly can, but we would, yeah, I mean, if this became a thing where we really were chosen to kind of be the platform that they used in an emergency shelter situation, we would think through all those things and have some kind of, you know, as efficient as possible data gathering form about patient information that the nurse would fill out, gather with address. Oh, see, look at that, they do have that,
Wait,
great.
you didn't probably get these folders.
No, we didn't.
I just walked
But
in.
we have, I mean, it does, it has a lot of the things you were
Oh,
just talking
okay,
about.
okay. That's what I
okay,
wondered,
good.
you know, if we start him on this medication,
Yeah.
and he's gone tomorrow morning, who's following
Right.
him?
Absolutely. No, literally, we showed up at 1:20 and just said, yeah, we can see patients, because that's what we can do. But that's great. Yeah, we'd need something like that so that it would be part of the pre-screening of the patient, identification, gather some demographics, and have all that, so we know who we saw and know how to follow up with them.